Traditionally, operations people tend to work in manufacturing environments or service settings where they are trying to make the best possible use of the available resources. Examples include like you're trying to optimize an assembly line for a manufacturing setting, and how are you going to put buffers between the assembled products? So that's one typical application of what operations people do. A recent wave even in the operations community is to use our methodologies to address problems within the healthcare domain. Again, you can think of the healthcare domain in two broad categories. One being similar to the factory setting, like you're optimizing how many beds you're going to allocate in a hospital, you're optimizing how you're going to schedule your nurses, how you're going to schedule your residents, and so on and so forth. But a new vein that hasn't taken so much attention, however, there is a lot of potential to utilize the fundamental methods of operations is these treatment decisions in healthcare. One of them being organ transplant decisions. It turns out that even though organ transplantation is such an important life-saving treatment for many patients, we may not be using the available scarce resources, in this case it's the donors, to the best of our ability. So one of the things we were asking ourselves is, first, given the scarcity of donors, how can we best utilize the available resources? In the United States, anybody in need of an organ transplantation has to join a national waiting list. With the advance of the technology, actually, there are two types of resources available for transplantation. This is true for pretty much any organ that is transplantable. The first and the major resource is those that come from deceased donors. And the second, which is becoming more and more popular, however, compared to the deceased donor case, still a small fraction, is those that come from living donors. Now, anybody who is claiming to get a deceased donor organ has to join the national waiting list. There is no other way in the United States. Now, when people join the waiting list, this waiting list, we can think of that as just a pool of patients. As soon as a deceased donor organ arrives to the system, there is a central manager of the system, which is named UNOS. It stands for United Network for Organ Sharing. As soon as an organ arrives, UNOS runs a matching algorithm to see how they are going to prioritize the patients in the pool. As a result, some patients are ranked first, second, all the way it goes down to the bottom of the list. And at that point, UNOS makes the organ offered to the first patient on the prioritized list. At that point, a decision-making process starts for the patient receiving the offer. Now, as it works in the current system, anybody receiving an organ offer has the right to reject it. And they have the right to do so without any penalty. So what this means is, when I reject an organ that I received today, I'm not going to be penalized for this, meaning I will not be bumped down to the waiting list for my rejection, due to my rejection. However, there is a downside as well. I am not guaranteed to reserve my spot that I was in today. Because, as I said at the beginning, the patients in the waiting list are perceived as a pool of patients. For every incoming organ, the prioritization algorithm will be re-executed to see who will be first, who will be second. Now, perhaps it brings us to the question of how UNOS is prioritizing these patients. Given that we analyzed only liver transplant patients in this paper, I just want to focus on liver prioritization algorithm that's being used. So patients are prioritized by where they are located in the country. So geography is the first tiebreaker among all patients. Within geography, they look at disease severity, how sick the patients are. And the more sick you are, the higher you are bumped on the prioritized list. And there are a couple other tie-breaking factors used at the other levels. Now, when we were talking with the surgeons about how they were making these accept or reject decisions along with their patients, what we have realized is they are constantly referring to three factors. There are probably many others depending on the situation, but the three factors emerged. One of them is the type of disease that the patient has and how severe the disease is, how much sick the patient is. The second factor that they constantly refer to is the quality of the organ that's being offered. And the third factor is, and they talk about this third factor in a very vague language, but maybe we can make it precise in the following sense. When they make a rejection, patients or surgeons on behalf of patients are making these rejections because they have an expectation of a better offer. Then we ask ourselves, how can we make this expectation accurate? How can we estimate this expectation accurate? And as we talk more and more on this topic, we realize that knowing who else is on the waiting list, so in other words, knowing the entire composition of the waiting list, is the best means to accurately estimate my future likelihood of offers, because I know the prioritization algorithm. So our goal in this project was to maximize the quality adjusted life years that the patient will realize when she's making the trade-offs between accepting and rejecting. We argued that the waiting list is the most useful piece of information to reduce the uncertainty regarding future likelihoods of organ offers. Therefore, we started with analyzing a setting where waiting list information is perfectly revealed to everybody. So I know exactly all the characteristics of everybody in the patient pool that I am actually competing with. So the gap between making decisions under a perfect waiting list information, and making decisions under no waiting list information at all is what we call the price of privacy. It's the price that the patient pays by not revealing the waiting list information. So that's what we labeled as the price of privacy. We have made the comparison between perfect and no information case, and what we have observed is patients that everything else held equal. Patients that are listed at the top of the waiting list and they know that they are at the top tend to behave more picky on their accept-reject decisions, which means they are more selective on the organs being offered. They are making more rejections because they know they are at the top of the waiting list. However, if you go in the opposite direction, if they know that they are at the bottom of the waiting list or towards the bottom of the waiting list, they are becoming less selective. They are acceptive of organs, even though they are the arriving organs are poor quality. So knowledge of the waiting list, knowledge of where you are on the waiting list has significant impact on the patient's accept-reject decisions. The average life expectancy of a patient is reduced by 5% if waiting list is not revealed to her. That's what we find. Or reading this in another way, an average patient can increase her life expectancy by 5% if she can get the perfect waiting list information. However, this is just an average number. The number varies depending on the characteristics of the patients. Like there are patients that have gained about 15% increase in her life expectancy, but there were patients who gained negligible, like 0.1% life expectancy, increased life expectancy. And we have looked at, okay, what are the type of patients that are making large gains? And what we have realized is patients that have less severe diseases are making bigger gains, larger gains. Similarly, patients that are younger compared to all elderlies are making larger gains. And as we were thinking about these results, it made very much intuitive sense, and we discussed these results with our surgical collaborators. And the intuition behind these large gains in these groups of patients is the fact that their upshot potential is really high. The benefit of transplantation for a younger patient is relatively higher than the benefit that an elderly patient will get. Similarly for the less severe disease cases. Another thing that was really interesting is we looked at the impact of the geography on the price of privacy. As I mentioned at the beginning, geography is a significant factor in prioritizing the patients. And what we have found is patients that join the national waiting list through more congested areas tend to have larger benefits of accessing perfect waiting list information. The way to understand this result perhaps is in a more highly densely populated geography like California, there are so many patients that are joining together with you. As a result, you have a lot of noise about where you are on the waiting list. However, in a very rural area, there are only a handful of patients that are joining together with you, and you have more precision about where you are on the waiting list because there is only a small count of patients there. Therefore, exactly revealing the perfect information has more value in a more congested system. In terms of the timeliness of this research, UNOS, as I said, recently started publishing partial descriptions of the waiting list. These are not as ideal as the perfect waiting list description. However, they are something. We went ahead with our optimization methods and analyzed how good is this partially published waiting list information. Actually, anybody can go to the UNOS's website today and can see the kind of information that they publish about waiting list. The information is basically the head counts in each category of characteristics. So if you know that your disease severity is of certain level, UNOS will tell you that in this range of disease severities, there are 20 patients. In this other severity of disease levels, there are 30 patients. And given that you know your own disease severity, you can tell that, okay, I am in this chunk of 20, and I am ahead of these 30 guys. You can reduce the range of ranks that you might be in. And we went ahead and tried to investigate how useful is this information. Like we mentioned that on average there is a 5% gap between perfect and no information. What happens if I tell you partial descriptions of the waiting list? And an amazing result, which we were very surprised about, is once you use this UNOS's new information that they publish through their website, that 5% price of privacy diminishes away. That partial description, even though it's not ideal, it's almost as good as the ideal description. And if you can use that information, you can basically eliminate all the inefficiencies due to not revealing a perfect waiting list information. So one of the implications of this finding is that whatever UNOS is currently doing is really a good thing. And through utilizing the information that UNOS publishes, patients can actually do better informed decisions. And as a result, this will, of course, have impact on the costs of healthcare, particularly, I mean, if you think we are talking about organ transplants, a liver transplantation on average costs $500,000 in this country. So better use of liver transplants, of course, is going to have a lot of impact on healthcare costs and utilization. From an operational perspective, I want to make the best possible use of this organ because it's a scarce resource. And when I make an offer, if I am the system administrator, from an operations perspective, I would want any offer that I make to be accepted. However, if you look at the data currently, about half of the liver offers, about half, a striking number, are being rejected despite the enormous scarcity of organs. However, if the allocation algorithm could also consider what the patients are going to do with their offer, we could demonstrate that they could make better use of the scarce resources.